Welcome to Oncology Radio. We are bringing you the latest information in the arena of oncology. Every episode brings you a new Maryland Oncology Hematology physician host, along with special guests in cancer research, new trials, cancer treatment, nonprofits, and cancer care. Maryland Oncology Hematology is broadcasting Oncology Radio from one of our 14 locations throughout Maryland. You can find Oncology Radio on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. So stay tuned and welcome to Oncology Radio.
Good evening. My name is Dr. Sarupa Sengupta, and I'm a breast surgeon with Maryland Oncology Hematology in the Rockville Division. I will be your host for tonight's podcast. As a breast surgeon, one of the most important tools in our arsenal against breast cancer is breast imaging. The use of mammogram, ultrasounds, and MRIs allow us to detect cancers at very early stages, thereby really allowing us to improve mortality from this disease. Those of you who tune in regularly may have heard me touch on some breast imaging topics in our last podcast. This topic is so near and dear to my heart and so important to me that I actually wanted to spend the next 30 minutes taking a bit of a deep dive into the world of breast imaging. For this reason, I've asked my friend and colleague, Dr. Sonia Kella, who is the director of Women's Health Imaging at Adventist Healthcare Shady Grove in Maryland, to be our guest for tonight. We hope that we'll be able to answer some commonly asked questions by both physicians and patients and give all of you some insight into just how important, but actually how approachable breast imaging can be. So without further ado, good evening, Dr. Kella. So nice to have you as our guest.
Thank you for having me.
Of course. Could you tell the audience a little bit about yourself and your background before we get started with the meat of this?
Sure. So I am the medical director of women's imaging for Adventist Healthcare in Maryland. And I've been serving in this community in the Washington, D.C. area as a dedicated breast imager for the past 12 years. Prior to that, I did my training in Michigan. And prior to that, I did medical school in Philadelphia.
Awesome. We are so happy to have you here. All right. So let's get down to business. The first topic I want to tackle today is the topic of breast screening. In the recent past, there have been a bunch of changes to the guidelines that have kind of changed our conversations around how we counsel our patients. It's quite frankly become a little bit confusing. Would you be able to give us a little bit of insight into kind of how these guidelines came about and basically how do we kind of untangle some of the information we have right now?
Absolutely. So that's a very important topic to discuss with patients. And, so let's go back in the history of mammogram screening. So mammogram screening became a standard of care in the late 1990s. And, for the first 10 years or so, it was really accepted that a woman should start at age 40 and have an annual screening mammogram every year thereafter. And then what happened was, in the early 2000s, we really started to look at, as a country, the United States started to look at the costs of healthcare. And one of the costs that they were trying to reduce is the cost of false positives and overtreatment. So what they started to do was study women who got mammograms every year and what their false positive rate was and what their risk for having treatment done that wasn't really necessary. And with that, they hired the U.S. Preventative Services Task Force to revise the guidelines to come up with a set of guidelines that was a little more cost-friendly, especially in populations that didn't have great access to imaging or the economics to really support a yearly screening program. While they acknowledge that the safest option is still to start at 40 and do it every year thereafter, it was sort of a suggested way to cut costs. So that's sort of where the diverging guidelines came about. So you have the traditional guidelines that were start at 40 and go yearly thereafter. And then you have the U.S. Preventative Task Force guidelines, on the other hand, that say start at 50 and go every other year. And then there's one in between as well, which we can talk about later.
Yeah, I was just going to say, I just wanted to clarify one thing for our listeners who are not physicians, what a false positive means. And please correct me if I'm wrong.
So,
yeah, go ahead.
So a false positive is anytime you have a mammogram and it picks up something that's not a cancer.
Right.
And it may lead to additional testing or a biopsy.
Perfect. Thank you so much for that clarification. One of the things that I kind of noticed, especially kind of in what you were talking about, is that in the United States, especially now at this day and age, a lot of women are working. A lot of women have access to healthcare. They have the means to kind of pay for healthcare screening processes. At this day and age, do the U.S. Preventative Service Task Force guidelines really apply? I mean, even in Montgomery County where we practice, like, is this something that we can use? Is it applicable still?
So our area, including Montgomery County and the greater Washington, D.C. area, has a very large workforce of women that are big providers for their family. Therefore, it is important that they consider going with the safest set of guidelines, which is really start at 40 and go yearly thereafter. In our case, in this area, I really don't think the U.S. Preventive Task Force guidelines can apply, again, because we're not underserved. We have a lot of access to healthcare. We have financial resources in this area. So really, there's no reason we shouldn't be opting for the safest set of guidelines.
Yeah, I think that's exactly correct. And I counsel my patients kind of in the same vein. That being said, I think the take-home point from this is, especially for our patient population, 40 and yearly. Would that be correct?
Yes, absolutely. I mean, anyone who does what you and I do know that starting at 40, the risk really does go up. And there's really no reason to skip that decade when it comes to screening.
I agree completely. I kind of want to move on now to another question that I get, again, on the topic of mammograms. A lot of women ask me, especially in our area, if I have to get a mammogram every year, that's totally fine, but I'm exposing myself to a lot of radiation. Is it safe for me to get a mammogram every year? What do we know about the risks? And can you speak a little bit to this topic?
So the thing to remember is radiation is all around us. And the amount of radiation that a woman gets from a yearly mammogram is so low. It's about the amount of radiation they get from one flight to California. So if a patient asks me, hey, look, I really don't think I should do this. I'm really worried about the radiation. I say, well, then I really don't want you to fly, because that's you're still getting radiation. So really, if we have to put radiation into perspective, the benefit of getting a mammogram is well worth the risk of the radiation it gives.
I think that's a really great way to put it, Dr. Kella. Thank you. That's actually kind of a very approachable, something that I can understand. We're seeing a lot more in practice of patients coming in with 3D mammography. Not only are they coming in with reports that have 3D mammograms, I have a lot of my patients who are asking me, hey, Dr. Sengupta, should I be getting 3D mammograms every year? There's kind of a lot of hype surrounding this topic. And can you tell us a little bit about 3D mammography? What is it? And is it actually a better study?
So actually, yes. So 3D mammography is considered the newer, better mammogram. And it really became mainstream in practice after 2010. And I think at the current time, pretty much every large radiology practice in our area is offering it. In fact, at Adventist Healthcare, all of our screening patients get 3D mammography as the standard of care. And the reason for that is because it does pick up more breast cancer. It picks it up earlier. It picks it up when it's smaller. It picks it up when it's more subtle. And it also reduces the need for us to bring patients back for additional imaging, because what it really does is it slices through the breast and gives us smaller sections of the breast to read, and gives us so much more detail about every little bit of breast tissue. So, we're much more confident when we have a negative mammogram. We're much more confident when we make a finding and want to, pursue it further. So it is really a better mammogram. It does not increase radiation dose, not the way that now it's traditionally done, which is it's just done as a 3D image. And then we use the data to make a 2D image from the 3D image. And then we also use the 3D images. So you're getting so much more for your money. You're getting so much more for your time. It's this, the same to actually less radiation dose than the traditional 2D mammogram. And it's actually better for dense breasts. And we can actually talk about dense breasts in a bit.
Yeah, that sounds great. I mean, I think that a lot of women, I've started counseling them as well, that the 3D mammogram is just a better study. And I think the biggest question that a lot of women have for me is it going to be covered by their insurance, or do they have to pay extra for these tests?
So currently in most cases, I'd say about 95% of the large insurers, including Medicare and Medicaid, will cover it for screening. Okay, so what we have found from our own practice is we have not had issues with patients getting a bill for the 3D portion separately when they have one of the major insurances, like the Blues, Cigna, Aetna, that whole group of insurances, and then Medicare and Medicaid. Now, there are some smaller insurances, so every woman is encouraged to check her insurance plan to see what the out-of-pocket cost is in some smaller insurance plans that may not cover it. And usually it's only about $50. It's kind of in that price range. So again, like I said, for the amount of extra information that mammogram is showing the radiologist, it's really worth it.
Yeah, I think that's wonderful. And especially because one of the biggest things that my patients always talk to me about is, oh yeah, they called me back for more imaging. And it's really stressful for the patient when that happens. So being able to decrease the number of extra images that have to be obtained is really pretty wonderful. So we're pretty excited about this technology. We have a lot of really good screening, right, that we've just talked about. Now, one of the things I want to touch base on are the results. Specifically, we get reports all the time that sometimes we don't really know what to do with, such as a BiRADs 3 mammogram. What is the BiRADs criteria? Can you go over that for some of the people who are not really familiar with reading breast mammograms when they come back? And is a BiRADs 3 cancer? What is that?
So great question. So I get a lot of questions from patients about BiRADs. So at the end of every mammogram report, every breast ultrasound report, and every breast MRI report, the radiologist is required by the FDA to assign what's called a BiRADs code. BiRAD stands for Breast Imaging Reporting and Data System. That's all it is. It's a reporting and data system. And it's a way to standardize management that comes from a mammogram. So if you see a BiRADs 1 or 2, that's normal. Okay, BiRADs 1 is essentially, I see nothing that I can even comment on. BiRADs 2 is, I see something I can comment on, but it means nothing. Like, let's say a patient's had a history of breast surgery in the past. We will comment on post-surgical changes. That's a BiRADs 2. Nothing to be done. So BiRADs 3 is very interesting. And BiRADs 3 means I see something, but as an experienced radiologist reading breast, I think it is a benign finding, and I am 98% sure. That means that there's still a 2% chance that I may be wrong in my interpretation. And so therefore, because of that slight chance, I would like to watch that area in the short term. And the radiologist will give a BiRADs 3 and then also define exactly what the length of the follow-up will be. So they will say, I want another mammogram in 6 months, or I want another mammogram in 3 months, or I want to check another breast ultrasound in 6 weeks. It will be a very specific management plan. And that's basically because we don't want to do too many biopsies on things we really think are going to be benign, because it's stressful to have a biopsy, from an insurance standpoint. We don't want to, over-treat and over biopsy people. We don't want false positives. We are trying to use our best judgment and do the best treatment for the patient. Now, when you get to a 4 or 5, that absolutely means you need a biopsy. Okay, so if you see that on your report, that absolutely means, yes, you need a tissue diagnosis. There's something there that could be a cancer. Remember, only about 45% of things we biopsy actually come back as anything abnormal. The rest of the cases come back normal after the biopsy. And then finally, a BiRAD 6 is the least common one used, and that's for a patient that we're following with imaging after a diagnosis of breast cancer that's still hasn't been removed surgically. So a patient has breast cancer, let's say, getting treatment with chemotherapy to shrink their tumor, and we are continuously watching that with imaging to see how it's responding to the therapy.
Perfect. That was so helpful. One question I just wanted to touch on, a BiRAD Zero mammogram, does that mean that everything is negative, or does that mean that we need to do more?
Oh, great question. And thank you for reminding me. Yes, there is a BiRAD Zero category. And in general, a BiRAD Zero is assigned to screening mammograms when there is either a finding that we want extra pictures on. So we're going to take the time to call the patient, bring her back to our department, and do whatever additional imaging is necessary, which is often mammogram alone or mammogram and ultrasound or ultrasound alone. And then the other scenario where we may give a BiRAD Zero category is when we need old studies. So a lot of women move or they switch facilities where they get their mammograms, and there may be something on the mammogram that we say, that looks like something was probably there on her prior mammogram. So before I do anything further, I want to work with this patient and get her prior imaging study so I can do a comparison. And so a BiRAD Zero in that case means we will reach out to the patient, we'll get their permission, we'll contact their old facility, and we'll get their old mammograms.
Perfect. Thank you so much. And I just want to put a quick note. I see a lot of patients in my practice who come into me with BiRADs 3 mammograms. And I'm actually really happy to take care of those patients and see them because it's a little bit anxiety provoking to have a result that says, hey, you may need to get some more imaging. So I'm happy to kind of discuss that with my patients. Additionally, in that 2% chance that their next set of imaging leads them to needing a further intervention, it makes me feel a lot more comfortable that the patient has somewhere familiar to land to discuss those results. So I'm always really happy to see those BiRADs 3 patients, but I wanted to just kind of talk about it a little bit because it's a pretty confusing topic for patients, especially when they get these reports. So
and I'll be honest, as a radiologist, it's not a categorization that we want to give often. We really reserve it for cases that it's appropriate to, rather than be aggressive and biopsy something, that we just want to give it a little more time. But by no means is it the most common designation we want to give. In most cases, we really want to give those 1s and 2s. And if we're concerned, we want to give a 4. So it's one of those, uncommon, but I'm sure you see it more often type of things.
Right. A lot of women, when they get their mammograms, are told that they have dense breasts. Now, breast density is a big topic that I end up discussing a lot with my patients because they have a lot of questions. There's a lot of information out there, both in the medical press and in the lay press. Can you talk to us a little bit about breast density, what it means and what it means for the patient?
Absolutely. So great topic and an important topic for women to understand. So breast density is simply the ratio of fat to the amount of glandular tissue on a mammogram. Fat shows up as black on a mammogram. Glandular tissue shows up as white on a mammogram. So it's the amount of, essentially we're measuring the amount of whiteness on a mammogram. And what's interesting is cancers are also white on a mammogram. So if you have a lot of glandular tissue and not a whole lot of fat, it's going to make the radiologist's job a lot more difficult to pick up those small cancers because our eyes rely on the contrast between the black and the white to pick up anything. One thing that really helps is 3D mammography, as I alluded to earlier, with dense breasts. Because of the slicing protocol that the 3D mammogram does, we are able to get more contrast on each image. So it does really help the radiologist pick up those cancers in dense breasts. But more importantly, women with dense breasts should know that they have options. So there's been no replacement for screening mammograms. However, there are some supplemental screening options. And those, really the mainstream one that you'll hear about the most is whole breast ultrasound. And those are, again, done as a supplement and basically are an option for women if they're told they have dense breasts, and that will work in addition to the mammogram to pick up any undetected areas that the mammogram may have missed due to the breast density. Other options include MRI. That is really reserved for our high-risk women because it's costly and, there are only so many MRI scanners that are available. And then some of the less common ones are nuclear medicine imaging, where you actually have a radio active tracer that's very safe, that's used in your body to try to bind to any abnormal cells in your breasts. And then there's a special camera that can pick that up. And then there's also, some of the less commonly used things like thermography, which will pick up heat inside the breast. Areas that are abnormal tend to take up more heat. So that's the thought behind that. And those last two are less commonly used.
That's really, really helpful. A couple of quick questions I have for you. It's obviously more difficult to find a breast cancer, right? If you're looking in the sea of white for something white. But do women with dense breasts inherently have a higher risk of breast cancer? Do we know that for sure?
Actually, yes. So on one hand, dense breasts make it difficult for the radiologist to pick up cancers. And on the other hand, they actually have shown some data, some research that proves that women with dense breasts are also more likely to develop cancer in their lifetime, breast cancer in their lifetime, because they simply have more cells there, more breast cells that can develop it. So it is considered a risk factor for breast cancer.
Right. Interesting. Also, you were talking about all of these supplemental screening modalities that are available to our patients. Does insurance cover these for them, or is it going to be an extra cost that they have to undergo to get this extra screening that they very well may need?
So very important question. So what's happening is there were a set of laws called the breast density reporting laws. And those have become passed throughout different states in the United States since about 2008. And Maryland and Virginia, and I believe DC as well, all have this requirement that the radiology facility is required to report on a woman's breast density. So, this is a widespread law in the United States. So what happened was, after that law was passed, women started getting their breast density on the reports. And then there was a lot of feedback from the referring physician community, like yourselves, and from patients saying, okay, well, now you told us we have dense breasts. What are we supposed to do about it? You told us this piece of information that we're at higher risk, but you haven't told us what we're supposed to do about it. So now there's actually a second set of legislation that's going through the state governance, and it's individual to the state. I believe it's passed in Virginia, but not in Maryland yet. I'd say about more than a third of the country has passed this legislation where if a woman has dense breasts and she opts for the supplemental screening, insurance is required to pick up that bill. And so for the time being, the most important thing for a woman to do is check their insurance plan, and then have that important discussion with their doctor. Do they have dense breasts, and is supplemental screening something they want to do? It is by no means considered a standard of care at this time,
okay,
but it is an important discussion for each woman to have.
That is really helpful information. Thank you so much. I mean, that helps kind of clarify so much about breast density, which is a very confusing topic, and kind of what is going on in the country regarding how we're treating these patients. So yeah, thank you very much for that clarification. Something I want to switch gears a little bit and talk about, we've spent a lot of time talking about screening and kind of how we screen and what we find and what we do with it. A lot of women come to me, especially after I've given them a diagnosis, and they'll say to me, Dr. Sengupta, this is so crazy that this is happening. Nobody in my family has any kind of cancer. How did I get breast cancer? And there are a lot of risk factors that we kind of know about and some that we don't really know very well. Can we talk a little bit about the risk factors that lead us to kind of a higher risk for breast cancer?
Absolutely. So this is a very common question we get in the breast imaging department too. And that is, if I have no family history of breast cancer, doesn't that mean I won't get it? And actually that is not true. The vast majority of breast cancers occur in women with absolutely no family history. And that's because breast cancer is a disease of aging breasts. So your biggest risk factors are the fact that you are female and the fact that you have breasts. Those are the biggest risk factors. Now let's talk a little more about some of the other risk factors that all women should be aware of. And when we talk about risk factors, we talk about modifiable risk factors and non-modifiable risk factors. So let's start with the non-modifiables first. So the age at which you started menarche, which is when menstruation started, and the time period between when menstruation started and menstruation ended, the number of years that a woman was hormonally, having menses, the longer that time period is, the higher the risk of breast cancer, because breast cancer, for the most part, is a hormonal condition. It's induced, for the most part, by hormones. There are some exceptions, but that's really the thing to keep in mind. So if you had an early menarche and a late menopause, that puts you in a higher risk category. Another non-modifiable risk factor, and this is something that's really happened in the last, 40 to 50 years, is women don't have childbirth before the age of 30 anymore in general. Okay. I mean, our society has changed, and education for women has changed, and their role in the workforce has changed. And so most women have childbirth probably in their, early, mid, and even late 30s, and even sometimes in their 40s. And that also is considered a risk factor, because the earlier you have your first completed pregnancy, the less of a risk it is for breast cancer, because somehow the hormones of pregnancy seem to cut off the process of the hormonal stimulation of breast cancer in the cells. So earlier pregnancy is also what I consider a non-modifiable risk factor, and that's dependent on your lifestyle and your situation. And then now let's talk about some of the modifiable ones, because these are the most important. So the modifiable risk factors we found is actually alcohol use. So heavy alcohol use, definitely higher risk of breast cancer. Normal weight versus overweight, definitely try to keep your weight normal. Try to get that healthy diet, that exercise in, because it does matter when it comes to breast cancer. And again, they think that has something to do with hormones.
That's so helpful. One of the things that a lot of women ask me is, do I need to stop drinking completely? And I kind of counsel them and say, decreasing your alcohol intake significantly decreases your risk of breast cancer. Now, do we need people to stop taking alcohol completely? Probably not. But especially, I think, in postmenopausal women, that risk factor is definitely plays a greater role than it does in the premenopausal set. So I definitely, want to make sure that women, understand that they don't need to stop drinking completely, but decreasing the amount that they drink is
all things in moderation,
everything in moderation. Exactly. So to wrap up, we've talked about a lot of really important and useful things in kind of the world of breast imaging. I kind of want to end our conversation talking about what's coming up. What are the things that are kind of, in the works right now that are going to either help or improve how we perform and look at and tailor breast imaging?
So absolutely, there are some very exciting things on the horizon. For me as a breast imager, the one that gets me most excited is there's a lot of research being done on approaches to screening in patients with a different demographic, and really creating, rather than a cookie cutter approach, which is, our guidelines, all three sets of guidelines are pretty much a cookie cutter approach, right? They tell you what age to start. They tell you, how often to get one. They tell you what age to stop. Well, a more tailored approach to screening, meaning in this woman, because of her family history, because she has dense breasts, she should really start at age, 40 and go yearly with both a mammogram and a breast ultrasound. But in this woman who does not have dense breasts, let's just start at age 50. She has no family history, no other risk factors, both modifiable and non-modifiable. Let's start at 50. And hey, let's try every other year, because she's, having a tailored approach based on the woman themselves. And that these algorithms, these protocols are being formed and studied at this time. Now, currently, nothing is accepted yet. Nothing is considered a standard other than following one of the, the sets of guidelines we talked about earlier. So I don't want any woman to misunderstand what I say and start, talking to their doctor about, having their own protocol, because that hasn't been accepted yet. But really, that's where we're headed in the future. I'd say in the next 10 to 15 years, we're going to see tailored approaches to screening based on each individual woman and her risks.
I love that. We have actually already started doing that in our cancer treatment protocols as well. Over the past even 5 to 10 years, we've really changed how we treat breast cancer and tailored the treatments to both the type of cancer as well as to the patient and her wants and what makes sense for her and her life moving forward. So I love that we're doing the same thing in radiology. It really does make such a difference that a woman knows that what she is having done is tailored specifically for her and her body. So that's going to be a really exciting thing when it comes up.
Yeah.
So Dr. Kella, thank you so much for being with us tonight. It's been incredible to have you as such a resource to talk about some really important topics in breast imaging. And to our audience, thank you so much for tuning in. And I hope we were able to answer some questions and provide some clarifications to both our colleagues and our patients about breast imaging and how it works. We're happy to address any questions, and our contact information will be provided at the bottom of the page in the link of the podcast. So thanks again for tuning in, everybody. Have a great night.
Thanks so much.
Thanks for listening to our latest episode of Oncology Radio. You can find the broadcast on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. You can find more information about our physician hosts from Maryland Oncology Hematology at www.marylandoncology.com. Subscribe to our show on Spreaker at www.spreaker.com/user/Oncology Radio. And remember to follow the guidelines and get your cancer screenings for the best defense against cancer.